Well, welcome. Thank you for joining us on today's vodcast from the Prostate Cancer Foundation of Australia. My name is Katie Clift. Very pleased to be facilitating and to be hosting today, and very delighted to introduce our guest, the esteemed Professor Dr. Axel Merseburger. He is the chairman of the Department of Urology at the University Hospital Schleswig-Holstein in Lübeck, Germany. He's an editor of the World Journal of Urology, and he's an international professor making significant contributions to the field of cancer research. We are very excited to have you with us today. And Axel will talk to us about the history and the impact of the Titan trial, how clinicians can navigate treatment options, and perhaps to look forward to what is next in terms of novel treatments for patients with hormone-sensitive prostate cancer. So welcome, Axel. Again, thank you for your time. And I'll hand over to you for presentation, background, and context, and we might get to a few questions at the end. So over to you.
Okay, thanks a lot, and thanks for inviting me to this podcast, sharing my insights and also the trials we have been working on. And here I'm starting with this highlight slide, this heading of the New England Journal of Medicine, and for us, as treating physicians, as doctors, as oncologists, as urologists, it's always like a groundbreaking news when something gets published in this very prominent journal. And I tend to read all the papers and all the publications in the New England Journal of Medicine, which are within my field of expertise, also my field of which patients I treat. And this publication is already almost about 5 years old, but led to approval of apalutamide, which is a novel hormone therapy for metastatic castration-sensitive prostate cancer, and really changed how we treat nowadays advanced prostate cancer. Let me explain to you the trial. Men with advanced and metastatic prostate cancer, they need to have had at least one distant metastatic lesion, like a bone lesion on bone scan, or a rib lesion, or some other metastatic sites that made them eligible to participate in this trial. And more than 1,000 men were randomized from 2015 to 2017 in 2 arms. One arm is the red arm you see here. This was ADT, so hormonal therapy plus placebo, the control arm, which was the standard of care back in 2015 when we designed this trial. And the experimental arm was adding to ADT apalutamide, which is a novel hormone treatment. And there was a very broad patient population included in this trial. There's a patient were permitted prior docetaxel. They could have been for some months on ADT. They could have had localized treatment of the prostate gland. So this was like the trial design. And the idea was that the overall survival and or radiographic progression-free survival, the primary endpoints you see on the right top in yellow, are positive. If this is positive, this trial is also read out positive for the arm apalutamide. There were some more also very important secondary endpoints like time to cytotoxic chemotherapy. So we and also surely the patient and carers try to avoid cytotoxic chemotherapy when it's not needed. And so if we have another alternative, like with a novel hormone treatment, this is always something the patient and also we as treating physicians prefer. The time to pain progression, the time to chronic opioid use, and skeletal-related events. Then there were some exploratory endpoints, the time to PSA, the prostate marker progression, secondary progression, symptomatic progression. So it's a well-designed phase 3 trial, which had the idea to approve this combination apalutamide and ADT in advanced metastatic prostate cancer. Those are the demographics and the baseline characteristics and what we can expect in such a large randomized controlled trial, that both arms were pretty well balanced. There are no real differences with regards to disease volume, Gleason score, echo performance status, even the age. You see here, median age was 69 and 68 years. And you could also see that age is not an inclusion, neither for the younger ones, where surprisingly like 45, 43-year-old patients with metastatic prostate cancer were included, nor the elderly, like up to 94 years, some of the men were included. Then you see also that about 10 to 11% of the men had prior docetaxel for metastatic castration-resistant prostate cancer. Disease volume, high volume in 60% of the patients. So it was really metastatic prostate cancer we are talking about here. For the first interim analysis, the follow-up and duration of treatment was 22.9 months. And you see here with the one view that like apalutamide ADT, 66% were still on treatment, ongoing. So they have had nothing, no side effects that bother them and no progression. Whereas in the other arm, the ADT only arm, it's 46% only still on this ADT monotherapy treatment. And this is the primary endpoint. Apalutamide significantly reduced the risk of radiographic progression or death by, as you see, the 52%. And you see the curves separate very early, and you have a very low p-value showing that it's statistically significant, and a very strong hazard ratio. Patients who were alive without progression, big difference, and the benefit, the winner was the arm apalutamide plus ADT, the patients that are here in this top curve. Looking at the radiographic progression-free survival benefit, it was consistent across the subgroups shown here. So regardless of echo performance status, geographic region, bone metastasis only at baseline, or visceral disease, prior docetaxel, age, and so on. So there was no difference in those groups, and so all patients really had a big benefit, a large, huge benefit, when a treatment intensification was performed for those men with advanced metastatic prostate cancer, and as you see here, regardless of the subgroups. Looking at the overall survival, also positive signal for apalutamide. It significantly reduced the risk of death by 33%. You see, the further the follow-up gets, the more the curves separate, and there's really a difference. And also, what is surprising, it used to be that after 5 years, a lot of those men with advanced metastatic prostate cancer died. But here, with this novel combination and treatment intensification, after 2 years, more than 80% were still alive. And as you recall, that was aggressive prostate cancer, 60% high volume disease. And this overall survival benefit was also consistent across the subgroups, as shown here in this plot. And to the left, it's always favors apalutamide combination if the ball is towards the left. Looking at the secondary endpoints I was speaking about at the beginning when I presented the trial design, like the median time to cytotoxic chemotherapy, it was much longer with the combination apalutamide and ADT, a p-value you see here, 0.0001, so very statistical significant. Some of the endpoints, the median is not reached yet, so we will have to await further analysis here. The exploratory endpoint also favored apalutamide ADT combination, so the time to PSA progression. And as you know from treating patients with prostate cancer, the PSA really plays an important role for the patient, for us as treating physicians, and also for the carers, because everybody knows who is has somebody with prostate cancer in the family or is himself sick or ill of prostate cancer. This marker is very reliable when it comes to seeing a patient recur or progress. So if you have a rising PSA, you know there's something happening and something not really good with your therapy. So I think this underscores the value of this doublet combination, and also translating in a better second progression-free survival. So this again supports that you should start early and don't go into the sequence. Don't just start with ADT, and when something happens, then go into some other treatment. So best put an all-in approach with a doublet therapy at the beginning. And here you see the median not reached for apalutamide, for placebo and ADT after 12 months. There was half of the patient that had a PSA progression, so 50%. So apalutamide combination led to a 74% risk reduction in those men with advanced prostate cancer. And here on the right side, secondary progression-free survival, apalutamide, 34% risk reduction, and a strong hazard ratio of 0.66 in favor of apalutamide combination. What has also been nicely shown and published out of the Titan trial is that after this first treatment, it's not the end. There are other subsequent therapies summarized here, like chemotherapy, iontherapy, radium, and other hormone combinations after those men progressed in both arms. And you see, it's still a lot possible, even when you started with a doublet therapy with apalutamide and ADT. So the question is, what is the side effect profile? And that's important to discuss with your patient, and also something you have to know when you treat men with advanced prostate cancer. You have to speak about it with your patient, and best also with the carers, so the families, children. So surely we have adverse events, but with looking at the more severe, the grade 3 and 4, have a look. The combination, 42% compared to the combination with placebo, 40%. So not really a big difference. Also serious adverse events, 19% to 20%. So really, this doublet hormone therapy didn't really add a lot to the side effect profile. What needs to be mentioned is that the rash is something specific for apalutamide. You see here most common adverse events leading to treatment discontinuation, where the rash, it's 2.3% for apalutamide versus 0.2% for placebo. So this is something what happens with apalutamide in a small percentage of patients. Summarized for you, the adverse events of special interest. So what do you have to tell your patients? As mentioned, the rash, all grades, so it happens in about 30% at some kind of degree that you see a skin rash, but this is pretty good to get treated by cortisone treatment or a pausing of the therapy for some weeks and then restarting again. And also like hypothyroidism can happen with apalutamide, but no grade 3 or greater hypothyroidism reported in the Titan trial. It's always good to look at the quality of life of the patients we treat, regardless of which oncologic disease they have, because I think that's what really matters. Surely it's prolongation of life what matters, but you want to also know if how much you, I don't know if it's the right word, but torture, or what's the problem, what can be like the quality of life with those treatments. And it's totally different to chemotherapy. In this doublet combination with apalutamide and ADT, you have basically an improved quality of life over the time. And this is probably due to the good tumor response and better well-being and health-related quality of life when looking at this specific FACT-P. P stands for prostate-specific health-related quality of life questionnaire. So I think this again underscores the value of not only having a life-prolonging combination with apalutamide and ADT, but also really preventing, conserving the quality of life in this doublet therapy. So I'm coming to my conclusions, and then I'm happy to discuss with you questions that come up. So we really have, with the Titan trial, a large phase 3 trial, which has this dual primary endpoints, overall survival and radiographic progression-free survival, which has demonstrated a significant benefit for the apalutamide ADT combination in a very broad all-comer MCSPC population. And the overall survival improvement was a 33% reduction in the risk of death. It's an rPFS improvement of 52%, reduction in the risk of progression or death. And those secondary endpoints also favored apalutamide. We have looked at the Kaplan-Meier curves. You remember, like the top one is the apalutamide, and the one that goes steep down was just ADT monotherapy in combination with placebo. And here, the Titan trial has shown that treatment intensification has led to a prolonged time to cytotoxic chemotherapy. And I think this is what the patient fears the most once they get chemotherapy. It's like at the end of the disease, it's MCRPC. So really want to avoid this. And here it's a 61% risk reduction. PSA progression, we have talked about this important marker, but also causes a lot of fear once you have rising PSA, surely 100% understandable in this metastatic setting. And here, the treatment intensification has led to 74% risk reduction, and PFS2 also 34% risk reduction. So I think this is some really good results, and that's why the New England Journal accepted the Titan trial for publication in 2019 because of this great result and this how do you say, game-changing data and guidelines-changing data. And it has changed our guidelines on how we treat prostate cancer nowadays. This combination was tolerable, and the safety profile was consistent with the known side effects of apalutamide. And what I think is also very good for our patients, that we can tell them that the health-related quality of life was maintained and did not differ from the placebo ADT arm. So in summary, I think we have a really guidelines-changing pivotal trial with the Titan trial, which led to approval of apalutamide in metastatic hormone-sensitive prostate cancer in a very broad patient population, regardless of previous therapy, regardless of doxycycline and MHSPC situation, regardless of disease volume or risk. Here, it was a very good benefit to that. So I thank you very much for your attention at this point, and I hand over to Katie for possible questions. Thank you.
Absolutely. And thank you for that very comprehensive overview. As you said, and as we can see, and those listening can hear, significant findings from this research. How does it translate, perhaps clinically, in terms of the clinical outcomes that we're seeing, this type of research? You mentioned affecting guidelines. Maybe talk us through, for people listening and tuning in, on the real clinical impact and outcomes through research like Titan.
Yes, it changed a lot. So when I started residency, we basically had just ADT 20 years ago. And then when it came to advanced disease, chemotherapy, and that's all. Now we have 2 handful of substances and different treatment options for men with advanced prostate cancer. And here the Titan trial has led to approval of combination of apalutamide plus ADT. That's why the guidelines changed, that ADT alone is not standard anymore. So patients which present to us in the metastatic setting should not just give ADT, what we've done 10 or 15 years ago. It should be at least a combination with a novel hormone therapy like apalutamide, or even a triplet therapy. We have some data now for those young patients with a high volume, high risk disease, where upfront chemotherapy is being given with novel hormone therapy combinations. But the monotherapy with ADT is really out. it's against the guidelines recommendation and should not be given anymore. And I think with all those activities in educating the doctors, updating the guidelines, having seminars and conferences, I think we all did big steps towards the right direction and treating the patient as he, in this case, should deserve.
I think we've seen a lot too in terms of the application of these novel hormonal therapies, right? What maybe can you talk to the fact that we're seeing them perhaps become effective or be tested in terms of their effectiveness earlier in the prostate cancer treatment cycle? So, and for different types of prostate cancer. So what can you tell us about the application of these therapies across that journey?
Yes, for example, in this apalutamide, there are several trials. One has led to approval in non-metastatic castration-resistant prostate cancer, which, for example, can derive out of a man that get radiated for the prostate with concomitant hormone therapy and then rising PSA again, or out of those times where we had just ADT monotherapy and the PSA goes up again, you do imaging and see nothing on the conventional imaging, then you have an approval and a label for apalutamide in a lot of countries. We've just discussed the HSPC situation for apalutamide, and there are trials exploring NHTs also in a locally advanced prostate cancer, so neoadjuvant and adjuvant to surgery or radiation therapy. And I think this treatment intensification moves from latest line mCRPC towards MHSPC, M0CRPC, and even like in localized disease, since we've learned that this led to overall survival benefit, to better prognosis of those men with advanced prostate cancer.
And we have a question that's focused on helping clinicians decide between these different treatment options that are available, right? What advice would you have in terms of navigating, maybe it's a very broad question, but based on your research, navigating and trying to come to these decisions in terms of clinical treatment options?
So for this metastatic prostate cancer, which is still hormone sensitive, what we discussed now, sure, we have almost a handful of options available. So we should not give ADT monotherapy. We should at least give a combination with NHT. And here I personally look at the options I have available now and later, because most of the men, unfortunately, after some years, will have a progression and they need second line, third line, fourth line therapy. And for apalutamide, for example, as an NHT, which is approved in MHSPC first line and not mCRPC second line, you could only give it in the first line situation. And whereas others like enzalutamide, you could give it at a later situation, or abiraterone. And also the mode of action is a little different with abiraterone as another NHT. So I think also thinking of modern combination when it comes to later treatment of prostate cancer in mCRPC, we have PARP combinations with abiraterone, with enzalutamide, but not as of yet with apalutamide. So if you want to use this good working substance, I think it's best advised to use it at the beginning. But surely it's not a mistake, and it's also covered by the guidelines to start with enzalutamide or to start with a abiraterone prednisone combination, or even considering a triplet, which is also approved in some countries like mine in Germany, starting with darolutamide, 6 cycles of docetaxel, and then continues with darolutamide and ADT. And I think I don't really have a clear-cut answer, and it would be unfair to just decide this is the best sequence or this is the best start substance or drug. I think it's important to discuss it with a patient, drug-drug interactions, frailty, situation of comorbidities, and fit for chemotherapy, for example. So I think those are a lot of factors. So we really need to offer our patients a very tailored approach. We have a broad label here for this, for example, this apalutamide, but we really have to have a tailored approach for our man with this otherwise pretty deadly disease.
You touched in your presentation too on that patient experience. I just wondered the strategies you might have for clinicians that are tuning into the podcast today in terms of dealing with patients. And as you had referenced to, not just the man affected by prostate cancer, their family, their network as well.
Yes, it's not so easy because we surely change the quality of life. The man comes for PSA screening, for looking for prostate cancer, and then you have to tell him, yeah, you have prostate cancer, and then you do imaging and you see you have metastatic prostate cancer. Those are all bad news and very hard to digest. And everybody who has family friends or himself or herself had prostate or some other cancer knows how devastating, how tough this can be to get this diagnosis. You immediately think of dying, or how much time do I have left? And I think here it's good to talk with the patient, to offer also psycho-oncologic support. And I'm a surgeon, I'm an oncologist, but I'm not the best for, I got some training, but I'm not the best for psycho-oncological consultation. And I think we really need to work in a multidisciplinary way in order to guide and help our patients in this situation. And then when it comes to the situation of metastatic disease, you can tell them we have new drugs that surely have an impact on your quality of life, like hot flashes and different ways on, like, the testosterone gets suppressed, you lose some muscle, so it's the other way around than doping. But on the other hand, you have a way to really make the cancer sleep for years in best. So I think this needs to be discussed. And here with hormone therapy, I think it's a quality of life better than the chemotherapy for most patients.
And we've seen, and you've talked us through the significant findings from this trial. We've seen significant strides too in the last 10 to 20 years in terms of clinical trials like this and movements forward in research. What do you see as the future in terms of this field of research, perhaps what we're going to see over the next 10 to 20 years, and how that might translate clinically for patients?
So, Katie, thank you. I think the future is that we have more precise information on which therapy works best with molecular markers, which can show us, so this is a patient that needs chemotherapy up front, or this is a patient where you should start with hormone therapy. So I think though this is still like not fully solved, and we know it afterwards, and we're smarter afterwards, the situation. And now I think there are developments and trials looking into prognostic factors, also looking into modern imaging like PSMA PET imaging, where you can maybe cure the cancer earlier when it's just one metastasis. You can maybe take out the lymph node or do radiation of a bone lesion. And I think here a lot of changes will happen in the next upcoming years.
So if people would like to find out more about you, your work, the commentary that you might have in this field of research, can they follow you online? Where do we find out more information?
Yes, I mean, you can find me online. If you put my name, Axel Merseburger, you'll find me on LinkedIn. I don't do social media consultation for patients because I think it's not fair. You need more time. So I'm on Twitter. I'm also on Instagram with my clinic. But it's just for general information and also for sharing the contact. And then I think it's important to trust your physician in your home country, your hometown. Usually they do a very good job, and but they can reach out to me, and they do once in a while by email or whatever channel. And I'm happy to support and answer questions, and I do this pretty frequently.
And as we wrap up, I mean, is there anything you would add or kind of summarize in terms of the information you gave us about this trial today, its significance, and any last message you have for people watching?
Well, I think it's good to consult the internet for medical information, but I would not just Google or put it in ChatGPT. I would trust like those patient advocatory forums, and where there's information or information on the trial from the manufacturers. I think this is all fair, balanced, and true. And not just fake news, what you can find a lot in the internet. So I think if you go on your country-specific, for example, in Germany, it's a German Association of Urologists, or the EAU, we have a patient guidelines from the EAU, which is patient-friendly and information material. And you can just go on the EAU webpage and you will navigate easily towards the topic which concerns you or which is your disease. And you find a lot of well-made information.
Excellent. So thank you again, Axel, for your time today, for covering this research, and for translating it in terms of being able to easily understand and looking ahead to the future of what this research might mean clinically. So thank you very much for your time.
Thanks, Katie. Thanks for having me here, and all the best.
And you can find out more details on clinical trials in Australia, internationally, and more details about, again, how that might translate clinically at the Survivorship Toolkit, which is available at prostate.org.au, or of course the Prostate Cancer Foundation of Australia website, pcfa.org.au. So thank you for tuning in, and we'll see you in the next podcast.